All right, good morning, everybody. My name is Ian Saldana, and I'm an associate professor here in epidemiology at the Center for Clinical Trials and Evidence Synthesis. Welcome to our first monthly seminar of the Center for Clinical Trials and Evidence Synthesis of the academic year. We thought we'd start off this year's seminar series by just giving you a flavor of what's coming up for the rest of the academic year. So as you see here, the dates of our seminars are here. So for the most part, there's a seminar each month, but as you'll see, we don't meet in January, and we have a couple of seminars for a couple of the months later, mostly next year. You see rows that are highlighted in blue here, and these are seminars that are jointly sponsored by our center and the Center for Drug Safety and Effectiveness, or CDSC, which is also here at Johns Hopkins. What you will also see is there's a range of speakers that are going to cover a range of different topics that span the breadth of clinical trials and evidence synthesis. We have Professor Marion Campbell, who I'll introduce in a moment later, who's going to give the talk today. And then we have speakers, for example, the chair of biostatistics, Dr. Elizabeth Stewart. I'm going to talk in October. The month after that, we have Dr. Robert Califf, who was the former commissioner of the FDA, who's going to be here. So that's going to be a blended session here as well as Zoom. Then Dr. Evan Mayo Wilson, who used to be here, is now at the University of North Carolina. Dr. Brett Toombs, who's at the McGill University in Canada. Dr. Gail Dommett, who's also from here at Johns Hopkins. Ivan Diaz, who's from the New York University. And then one of the things we're introducing this year is more content related to dissemination of findings of clinical trials and systematic reviews. Dr. Catherine Wu, who's a science writer with The Atlantic, will be presenting in April, and then a couple of seminars in May from Dr. Stephanie Chang, who was the former director of the ARC-EPC program of the Evidence-Based Practice Center program, who's now a deputy editor of Annals of Internal Medicine, and a former student who's going to close us out for the year, a former student of our center, Jerry Jianyu Yi, who's now working at Sanofi in Cambridge in Massachusetts. So it's an exciting suite of speakers that we have lined up for this year. We're hoping that you'll attend many of these, if not all of them. You're obviously on the list, or you found out about this one, but if you need more, if you need to be officially added to future lists, Amy Zemanek is the contact person. Amy's on this chat as well. And if you want to look at past seminars from our center, you can look at them at that website link. It's basically our center's YouTube channel of past seminars. Okay, great. Thank you, Amy. You can take that down, and let's move over to Dr. Campbell sharing her slides. But while she's doing that, I'll introduce her. So our first speaker for this academic year is Professor Marion Campbell, who's a professor of health services research at the University of Aberdeen in Scotland. She's also director of the Royal College of Surgeons, Aberdeen Surgical Clinical Trials Centre, and a member of the UK Medical Research Council Training and Career Strategy Board. Dr. Campbell's training is, she has an MSc in statistics and a PhD in public health from the University of Aberdeen. And her main research are in the design, conduct, and analysis of clinical trials of complex interventions and of surgical device and critical care clinical trials. She's published widely on clinical trials methodology, including on cluster randomized trials, designs of trials of surgical interventions, pragmatic trials, and trials reporting. And she's an elected fellow of several societies, including the Academy of Medical Sciences, the Royal Society of Edinburgh, and the Society of Clinical Trials. So thank you so much, Professor Campbell, for kicking us off this year. Welcome, and over to you.
Well, thank you so much for inviting me. I was really excited to join this seminar series. And when I see the other people who are speaking, I feel very honored to be on the list alongside everybody else. So thank you so much for the invite. You did mention pretty much all my disclosures in your introduction. There's nothing unusual about this. It's standard disclosures, but I also chair one of the UK's large funding panels around better methods research, which is quite an unusual funding panel here in the UK, but it's one that is maybe one that we could work with internationally to promote methods research. But anyway, today I'm going to talk about complex intervention trials and some of the methodological challenges around that. But a little bit of background. I mean, many of you, I'm sure, are very, very aware of what complex interventions are, but it's always helpful to start at the beginning just to make sure everybody's on the same page. And so if we think about trials interventions, generally speaking, we can classify them as either simple or complex. And depending on what that classification is, that really has quite extensive consequences for how we design our trials, how we conduct them and how we analyse them. But I think it's important that we spend just a couple of minutes working out what determines whether something is simple or complex. And your traditional simple inverted commas intervention is one that has been deemed to have a single primary component. I mean, your traditional simple intervention's a drug that you would use in a drug trial. It has a primary component. It is the drug that you are issuing. The mechanism by which the intervention influences the outcome is generally known. So if you have a drug intervention to lower blood pressure, there is the early preclinical work to determine what mechanism by which that agent interacts. And there's a direct link then between the intervention and patient outcome. So in this case, blood pressure measuring a drug for the management of hypertension. Complex interventions, however, are, as their name implies, more complex. They are usually multifactorial, and they have multiple agents involved in it, and I'll give a couple of examples later. Very often the intervention itself is a component of a wider health system. Components can act interdependently, and this causes issues when we try and evaluate them. And indeed, there may be some dynamic interaction between the intervention and the system itself. So we need to go into these complex intervention trials very much with our eyes open. And so there has been in the literature this discussion that there actually is a spectrum between a simple to a complex intervention, that it's not a dichotomy, and every intervention moves somewhere along the spectrum. And way back in 2000, Medical Research Council issued their very first guidance on complex intervention. And I like this definition. So the greater the difficulty in defining precisely what exactly are the active ingredients of an intervention and how they relate to one another, the greater the likelihood that you are dealing with a complex intervention. It explains really nicely the fact that these are not clearly delineated agents within an intervention, as you would have in, as I mentioned, a drug trial. So we move right along from the simple end, where single agent, single mechanism. You move along an increasing spectrum of complexity, right up to your very, very complex system change. So your traditional, you would call a stroke unit. A trial of stroke unit versus standard care would be your ultimate complex intervention. You've got no real idea of what stroke unit means, what that bundle entails within that intervention, and similarly standard care could be quite variable. So let's then look at some of these examples in the literature, and following the theme of a typical example of complex intervention, I raised one here that I was involved in the early 2000s, very typical example of its genre. This is the practical study. It was a nurse-led intensive care follow-up program. So many of you may be aware when patients have a stay in ICU, they can often have no memory of what it is like being in ICU. They may have been exposed to episodes of delirium. There is distinct muscle wasting. There is much body weakness afterwards. And so there is a a multifactorial need for these patients once they've been discharged from critical care. And so one intervention that we were examining at the time was whether having this intensive care follow-up program would certainly help patients get back to a certain level of health and well-being afterwards. But and this is the actual publication of the trial. But for our purposes, let's look at the intervention. So this actually was the practical trial intervention, and it was multi-component. It had a formal review of drug therapy for each patient. It had a visit to ICU. So I mentioned this issue about delirium, and actually it was found that actually if some patients went back into ICU, they would see the things and the noises they had been hearing that were quite horrible to them were actually machines and quite safe things. For the muscle rehabilitation, there was often the need for physiotherapy or occupational therapy. It was a formalized rehabilitation program. There was that case note review with an IC nurse to really walk through what had happened. And there was also the possibility of psychological screening and or referral, depending on results. So you can see a huge bundle of things going on here. The multiple components could interact. So for example, if people had experienced delirium and they were experiencing after effect of being in ICU, then they might be more likely to need psychological screening and referral. And all those things could then attenuate the effect of the intervention. And all interact with the wider health system. So these things didn't sit in a vacuum. They were within the wider healthcare system that looked after patients as they left intensive care. So this is your traditional example of what a complex intervention looks like. But actually we're learning a lot more over recent years that it isn't just an intervention that looks like this that's complex. And that things that we might traditionally have thought were simple are actually complex, and we should treat them in that way. And I think one of the less well-recognised complex intervention, but which we are really beginning to understand now, is surgical intervention. So the traditional paradigm of these was, this is simple, somebody comes in, they've got, appendicitis, one would go in for a, inverted commas, simple procedure, appendectomy, and cause and effect. And that's the assumed surgical procedure. It has a single primary component. The mechanism by which the intervention influences outcome is generally known, and a direct or single link between procedure and patient outcome. But what we're actually discovering now, or understanding really now, is that actually surgery is a complex intervention, and delivery of a surgical procedure is so much more than the procedure itself. There are multiple co-interventions. There's, the concomitant anesthesia. There's the pre-operation optimization. There's the post-operative management. There's also the surgeon themselves. They have their own learning curve in learning how to do a procedure. They have differing levels of expertise. The operating team are also learning. But also, if there's a new surgical procedure, they need to reconfigure how they organize themselves and how they learn to integrate a new procedure into the pathway. And at the highest level, the organization itself needs to incorporate new procedures and new pathways into planning. So something that can be described very simply is actually also a complex intervention. And again, just following along that line, what we're now beginning to understand is that devices are also complex interventions. And here I'm describing a study that I was involved in just a couple of years ago. And this is looking at how do you manage patients who have been, say, in a very serious car accident, and they have very, very serious injuries, and they have uncontrollable bleeding. This Reboa device, which is this picture in the middle, has been thought that if you can wire up this catheter, feed it in through the femoral artery, take it above the site of the bleeding, blow up this balloon, which you see on the catheter wire, And then that stops the bleeding, and that then allows temporary control until you can get the patient to hospital. But what we're finding is it's not just the device, absolutely not just the device. What you are actually, you require an entire team to deliver this device. There's multiple players, there's the paramedics, there's the emergency room team, there's the dedicated or designated robot operator who will actually insert the catheter into the patient. All of these people have their own learning curves. And when you introduce a robot technique into the system pathway, the pathway needs to change because you're not going to theatre in quite the same order as you were, and you're not getting CT scans at quite the same time. So what seems a very, very simple device in that picture in the middle actually is a system intervention that's actually complex. And so we are now finding that there are many interventions that we need to now begin to look at through a complex intervention lens. But why is it more difficult to evaluate a complex intervention? Well, typically the things that we find are problematic is it's hard to standardise the design and delivery of the intervention package. And I'll talk a little bit about this later on. It's very hard to pin down the causal links between which is the intervention component that's working in the outcome. It's difficult to know how the components interact. They're often sensitive to local and contextual factors, and sometimes lack of effect may actually be about implementation failure in the hospital or wherever, rather than actually genuine ineffectiveness of the device or the surgery or the intervention itself. And we need to be really aware of this. And so thinking about the things that can help, I mean, many of you will be aware of the complex MRC's, Medical Research Council's, very well-known complex intervention framework. And this was developed first in 2000 and then refined again, I think, in 2006. But the most up-to-date refinement has been in 2021. And so this framework is all around supporting complex intervention evaluation. It fully recognises complexity. It outlines how you need to take account of context when you're evaluating complex interventions, how you need to accommodate for these interdependencies in the wider system, and really stressing that you need to really, really, really spend your time understanding the intervention and the intervention delivery. And so this is the framework, and you will see there are multiple components here. If we start on the left, we see here that there's an entire section around developing the intervention or identifying the intervention. There are then elements on the top there about spending time ensuring good feasibility work is there to look at the feasibility and acceptability of interventions. There on the bottom, we talk about implementation. And in the middle there, you see about engaging stakeholders, identifying uncertainties. And it's only right at the very end on the right, you see evaluation. And to be honest, this is exactly what it's like in practice. You spend 80% of your time doing a complex intervention trial on the upstream stuff, and you do 20% of the time actually doing the intervention. This is if you want to do one well and be able to understand things, you need to spend the time in the development and understanding of the intervention and optimizing that ready for your trial before you just go wholesale into doing evaluation. So a few general principles that the framework shows. And it starts with the one I've just mentioned, that a really good theoretical understanding is needed of how the intervention causes change. So it's really important you spend time understanding the intervention before you evaluate it, and I'll talk a little bit about that. Feasibility work is absolutely essential, and you need to fund that as part of your complex intervention trial. You need to be pre-planning it. Refinement and pre-optimization of the intervention is key. But especially it is really important that you keep ongoing assessment of the intervention across the lifetime of your complex intervention trial. So with that background, these are some of, there are many, many methodological challenges in complex intervention evaluation, but these are the ones I think it would be helpful to really think about a bit more closely. There's a serious challenge about how to develop the intervention appropriately. How can we identify active ingredients? How can you specify your intervention appropriately? How is it best to understand the mechanism of action? Similarly, the challenges around understanding intervention delivery. How do we go about understanding barriers and facilitators to intervention uptake? How can we understand the impact of implementation? And how do we assess the anticipated mechanism of action? And so these are all methodological questions and methodological challenges that we really, as trialists, need to bend our brains to and make sure we're adopting good methods and advancing the methodological responses to this. There's also how one assesses the impact of context. And what's often not thought about is actually the impact of the chosen control group and the methodological challenges that can rise. So I'm going to take these sections in turn, talk a little bit about the methodological approaches, give some examples about how we've used it in practice, and then we can have a chat at the end about, some of the specifics and anything you want to talk more about. So let's then look at the methodological issues around developing the intervention. So there are some really crucial methodological issues here that we do need to take into account when we're thinking about intervention development. There's a big role for the role of theory. We need to think importantly about pilot and feasibility work. And probably what's less spoken about is pre-optimization of the intervention ready for evaluation and implementation. And then I want to talk a little bit about some emerging new approaches that are gaining traction in this field that may be of interest to you moving forward. So I mentioned the real importance of theory in intervention development, and we as methodologists have our part to play in this to ensure that we contribute to the development of an underpinning program theory or logic model around intervention development. We can't just sort of say, oh, let's take some random components off a shelf, put them together, and we run this intervention. So we need to be thinking about what the anticipated mechanism of action is for each component of the outcome. Try and map through before we even start what we think the underpinning causal assumptions are, and then within our pilot work, constantly revisit and redefine this logic model as we learn more about it. So if you've worked a lot with behavioural scientists or with social scientists or system evaluators, very much the idea of starting your evaluation with the outlining of a program theory or a logic model is key. It's less automatic for a standard clinical trialist to think about this, but it's really, really helpful in the complex intervention scenario. I mentioned pilot and feasibility work, and this is utterly essential. You can use this to actually formally evaluate and examine each different element of the intervention to find out which are acceptable, which are feasible, which are implementable. It helps avoid redundancy in the components, so it helps you not have that analysis problem at the end of the study when you're trying to tease out what belongs to which component and where there are interactions. And again, as I mentioned earlier, this allows refinement of the logic model. But I think one of the most helpful things that one can do is start pre-optimizing your intervention before you take it to trial. Think about the implementation from the start, because you're wanting to ensure that what you're evaluating is the real thing and not poor implementation of the intervention. And so it's really important to think in advance, what are the barriers and facilitators to good implementation of your complex intervention? And here I'm just going to give you a brief example of one of the ways we did this in a study it's actually still ongoing, but this is about the intervention optimization. It's called the Reinforce trial. This is one of the newfangled complex interventions I mentioned. This is about robotic assisted surgery. We are evaluating the introduction and scale-up of robot-assisted surgery across a plethora of different specialties here in the UK National Health Service. But anecdotal evidence suggested that in some sites, the senior management might purchase this very expensive robotic surgery unit, and then it wasn't implemented appropriately. It was sitting idle half the time. People didn't know how to use it. They didn't know how to train it. And so this seemed totally inappropriate that we would be evaluating something that nobody had thought about how to optimize it. So we did a formal intervention optimization study ahead of our full evaluation. So what did we do? Well, I mentioned the role of theory earlier on. So we took a number of underpinning theories about how people implement things well. We took some theories from implementation science, and we did a diagnosis of the barriers and facilitators to actually implementing robotic assisted surgery well. We used what's called the TDF, the Theoretical Domains Framework, which is a theory-informed framework around what influences domains of individuals' behaviour. We also did the CFIR, which is the Comprehensive Framework of Implementation Research, which focuses on organisational and system effects. And so we focused very particularly asking, surgeons, team members, organisational managers, and so on. We did a direct deep dive on the things that affected implementation or not. And so we came up with a full diagnosis on the basis of our behavioural investigation, and actually found there are 3 very specific phases to implementing a robotic assisted surgical system. There's a lot of work with different barriers and facilitators pre-implementation, one in the early phases of use and one in the later phases of use. And what we found actually in most of the sites we were focusing in was they had spent a lot of time in the pre-evaluation phase and thought very little about what would happen when this very expensive piece of kit arrived and how it would be used appropriately. So on the basis of our theoretically based diagnosis, we were able to come up with effectively a treatment prescription, so that with known solutions that would lead to evidence-based solutions that would lead to targeting certain barriers and facilitators. And so we were able then to work with the individual sites, use some behavioural science techniques to help them pre-optimize the implementation of the robotic system. So before we ever started our full-scale evaluation of the complex intervention, we were going in with an optimized intervention. So I think this is a really important message: is think about your intervention, think about maximizing it and optimizing it, dealing with all the barriers and facilitators before you go to the full-scale trial. So the last bit in this section I want to talk about is some of the newer approaches. And one of the newest approaches that is gaining a lot of traction in the complex intervention field now is what's called the MOST approach, multi-phase optimization strategy. And this came from the field of engineering. It's about, again, optimization of the content of a complex intervention. It's got 3 main phases: preparation, optimization, and evaluation. And there's a couple of references here, but Linda Collins is the main developer in the healthcare field of this approach. And so you can see many examples from her work around this in practice. But this is it in a nutshell. So one would develop your conceptual model as normal, and you would then do a very specific optimization phase again, and only when you were convinced the optimized intervention was ready would you move to the evaluation. So it's a similar story, but enacted in a slightly different way. So again, the preparation model, thinking about, your conceptual model, you would very systematically now identify your candidate components, do the usual, conducting the pilot work for initial acceptability, and then you would come up with what's called the candidate set of intervention components. So if you go back to my practical example, you may actually find after piloting that you would only use 2 or 3 of them. But there are ways you can experimentally test which are the intervention components that you should include. And this is using what they call an optimization criteria. So you would want to actually scientifically test each individual component and set, for example, an effect size threshold that you'd want individual components to achieve before they would pass the threshold to be included in the final intervention. And the way you do that is through the optimization phase. And you conduct what are called optimization trials. So you take the individual components and you do very short factorial or fractional factorial trials. So what do I mean by that? So you will see here on the right, you basically turn each individual component on and off in a series of scientific experiments. And so you then use the optimization criteria you developed before to see whether that particular intervention component made the grade or not. And so you use these very scientific experiments to actually refine the intervention on that basis. So it's much more objective than, say, the mechanism that we had done for the refining of the intervention earlier, which is very much looking at behaviour and behavioural models. So this is quite a nice and very nicely objective way that we can start to build up which intervention components should be included and which not. And then you would move to the formal evaluation of that optimised intervention package. And you really only progress when you have fully refined it. If you need to do more work, you go back round the loop, back into the preparation phase, back into optimization, and only when you're ready do you come to the definitive RCT. So there are some emerging examples. So here's one from the UK, and again, there's many examples of these if you want to look them up. But this is looking particularly at this sort of optimization phase with the factorial trials. So this is the Rosetta trial, and that's being run out of Leeds in the UK. And they are using a partial factorial trial to try to optimize a complex intervention to support adherence to adjuvant endocrine therapy in women with breast cancer. And they have 4 different elements they're trying to see which should be in. They've got SMS text messaging, they've got patient education, guided self-help, and online self-management. And they are currently going through this sort of switching on-off in the experimental mode to find out which ones show most promise about taking forward into the full evaluation. So I think that's something that we will see a lot more of in the methodological sphere of complex intervention development and evaluation moving forward. So let's spend a little bit of time now. Let's move away from intervention development to understanding intervention delivery. And so here, there are some other key methodological considerations is, how do we actually track what's going on and how do we understand the role of context? And the main sort of methodological armamentarium we have here is what's called process evaluations, which again, I'm sure many of you are well aware of, but I'll spend a little bit of time just explaining it for anybody who's not aware. So process evaluations are integrated studies that formally examine the quality of the intervention implementation. So this is when you're running your trial. Is the intervention being delivered as you'd wished? And how is the context, or is the context at all, influencing that implementation? And so there was a really nice paper written alongside the Medical Research Council guidance that explains nicely, the power of process evaluation. So I've got that reference there if you want to go and look at that. And in that paper, it shows how context runs along the top. And even once you start going into your implementation, the context can really have an impact. Now, what do I mean by that? So, for example, if I go back to our surgical example, if you're in a very sort of high-performing, highly efficient hospital site, you're much more likely, sort of with a early adopter mindset, you're much more likely to integrate something like robot-assisted surgery very quickly than if you are in a brand new site that have never used technology like this before, and they have slightly more clunky systems for incorporating new things. So you will very likely see different effects in those two sites. So you do need to be on the alert for how context may mediate or moderate that effect in your intervention. So in practice, process evaluations measure certain things. They particularly look at fidelity. To what extent was the intervention delivered as intended? It looks at effectively the dose. What was the quantity of the intervention that was delivered? It can interpret and help explain mechanisms of implementation. How was it delivered? What things, changes that were made encouraged its delivery, and by whom? And then again, this role of context. And so you can use these process evaluations both to explain things when you get to the end of a study, or you can use it to almost adapt in real time in complex intervention evaluations, such that you are routinely optimizing the intervention as you go through. So methodologically, how do you do this? It's usually a mixed methods approach, usually a mix of quantitative and qualitative approaches. We might track routine monitoring data to look at, say, throughput or usage. We might do some documentary analysis. So this might be, looking at sort of actual, as it says, documents in use in the ward or the hospital that would indicate, the flow of the intervention and use of it in practice. You might use some interviews with the key players to actually be able to get them to untap, where the blockages have been or how things have worked well and so on. And then you can also use direct observation of what goes on when the intervention is being delivered. And so again, I thought I'd give you a little example of one that we had used in practice to show you the types of things we did and the types of things we were able to influence within our complex intervention trial as it was running. So let's go back to that UK REBOA trial. So this is the one with the very severely bleeding patients. We wanted to make sure that as the trial was running, that the intervention was still being delivered as expected. And so in our sort of routine trial meetings, there was some suggestion that potentially the recruitment of some patients was being missed, and also that the delivery of the intervention on some occasions wasn't quite as sharp as we would have expected. And so we used our process evaluation to explore this a bit further. So as before, we spent a lot of time, again, using theory-based interventions, theory-based interviews. We like using behavioural science in our unit, so you don't have to use behavioural science, but we did. We like it, we understand it. So again, we use the theoretical domains framework here to try and unpack what the barriers were to actually the intervention delivering as we'd anticipated over the lifetime of the trial. And this is just a picture of us in one of the training sessions, trying to do a bit of observation, seeing who was doing what and were they doing what we thought they would be doing. And so what did we find? Well, we actually found some key things that were still required during the delivery of the trial to make sure the intervention was still being implemented as expected. We identified that we needed to stand up extra routine training on a regular basis, so regular check-ins. The main reason being that this REBOA technique was actually, you didn't meet patients who were this seriously ill that often. And so, it was a case of, you wanted to have it almost immediately in your mind what needed to be done. We also even required to do environmental restructuring within the emergency rooms. So we actually found that where people stashed the REBOA catheters and the REBOA kit made it really difficult for them to have a very smooth and efficient implementation. So we actually got them, some of the emergency rooms, to redesign where they position their kit and so on. We acted up some enablement, allowing them to be able to recognise eligible patients very quickly. And there were some issues around just, reinforcing clinical importance and persuasion. So these were things we really would never have predicted, before we'd done our process evaluation, especially things like environmental restructuring, but that came out as something that was really clear to ensure that fidelity remained high, the dose of intervention effectively remained as expected, and the implementation. So I think this is really important insights into actually, you can't just leave a complex intervention trial up and running and then sort of expect it to just deliver perfectly. You need to have an integrated process evaluation so you know what's going on, you can explain the results down the line. So I mentioned the last few things I think now is I mentioned the choice of control group. And we often find in complex intervention trials that we compare them against this thing called usual care. And there are key methodological issues, again, to be aware of here. One serious one is the potential for contamination from your intervention group across to the control group. But probably a lesser known issue is the variability in usual care, which actually affects outcomes and can really affect outcome of complex intervention trials. So complex interventions, as I've mentioned, usually have system-wide effects. They're operated within a system, a healthcare system. There's real potential for learning from the intervention to cross over to the usual care group. So, you may find that, if you're learning to use, so going back to our, critical care example, if you are learning about how to better manage patients post ICU discharge, and you compare it to usual care, well, it's pretty much the same system and the same staff who are still delivering, care. And so there is potential for cross-learning from the complex intervention. This worked really well. So usual care, then there can be some drift in usual care as your trial goes on. And it's really important that you assess this in the piloting phase, because in theory, these interventions may still be being applied to an individual patient, but you need to be really careful that there isn't this sort of contamination of intervention effects across the wider system. And, traditionally, and it's the case in this as well, if this is an anticipated issue, then you really have to be thinking about do I need to change my complex intervention trial into a clustered design such that I minimize any potential for contamination across groups? Of course, if you integrate a cluster design, you then, of course, run into the other methodological problems about lower power. You need to have much greater sample size for that to answer the same thing. So ideally, you would not want to be in the cluster space for here, but it's something that, again, you want to find out early. You do not want to find this out midway through your complex intervention trial evaluation. The other probably less widely known thing is about the scale of variability in usual care. And not only that's variable, I think we all know there's some level of variability, but actually sometimes the scale of variability can actually affect the effect size. And I've highlighted some papers here. Marion de Bruin, who is based in the Netherlands, has spent quite a bit of time looking at usual care as a control group, and has actually found that sometimes the level of variability in the usual care is even larger than the effect size you're looking to detect in the actual study. And we see shades of this in some of the rehabilitation trials after critical care. We see some highly variable levels of provision in usual care. And in some, usual care at some sites is so good, it can almost be better than the proposed effect. So again, it really is important that not only do we concentrate on the intervention, but actually we have to understand usual care well. We cannot just assume usual care is the right comparator. It probably is the right comparator, but we need to be able to understand it and understand the variability between it. We need to methodologically assess the potential for impact on the effect size before we start our evaluation. We also need to monitor any drift in usual care over time, as I've mentioned. And there's, linked to this is the potential for Hawthorne effect. As a system learns, it gets better. And therefore, the usual care group just gets better because you're looking at it and you're exploring what happens there. So really important that don't always just focus on the complex intervention, also focus on the usual care comparator group. So a couple of take-homes for me to wrap up now. I think my summary really is complex intervention trials really are methodologically challenging. Serious preparatory work is required. And if upfront methodological challenges are not addressed, you have serious and major problems for downstream problematic trials. And so now, moving forward, I think any of us who are in this complex intervention space need to be seriously considering optimized intervention composition. You need to be pre-optimized for actual implementation, definitely have an integrated process evaluation, and have a well-understood control group. And then very finally, we must report them appropriately. I mentioned a lot about pilot and feasibility work. If we don't report this, nobody else will know the issues that we've come across and learned from them. There's good guidance on how to report pilot and feasibility work. We should, of course, report our trial results. And if any of you are not yet aware, there is a fully new and updated concert statement, which was issued a couple of months ago on the reporting of clinical trials. There is a dedicated reporting statement for how to report interventions clearly and acceptably. And then there's a guidance in development and due shortly on how to appropriately report fidelity of interventions. And then, of course, use any other relevant guidance cluster if you use it and so on. So on that note, I'm going to finish up and then open for discussion. So I think what I'll do is actually stop sharing my slides so that I can see people and have more of an active discussion. Thank you.
Good. Thank you, Professor Campbell. That was great. I mean, there's a lot of important methods, theories, frameworks, and examples from your work and others as well. So that was a wonderful introduction to trials of complex interventions. So if people have questions, maybe just raise a hand through Zoom or come on camera and raise an actual hand. I see a question in the chat that I'll start with from Bunyan. Are there guidelines? So I think you eventually got to this. I think the question was from earlier. Are there guidelines for choosing complex intervention criteria? I guess the latter half of the question is it per the investigator's discretion? So maybe if you can talk a little bit about choosing among frameworks that might exist and what might drive some of those choices.
Yeah, so I think there's a couple of things. I think you know, you're also talking about what should go in the complex intervention in the first place, and I think that each probably complex intervention developer has probably a epistemological stance, you know, about how to approach this. I think the most important thing is that you are very rigorous in how that is done. You have a clear process by which you now decide what should be in or not in a complex intervention. And I think the transparency is key about how you get there. And as I mentioned midway through, I think the most approach will become much more prevalent. And of course, that is very much an objective way of doing it. You're starting with this effectively as a mapping review of possible intervention components, and you're using them experimentally to run them down. But I think if you look in the literature, there's a lot of work around the types of framework that might inform a process evaluation. And these sort of elements, I mentioned obviously a couple from behavioral science that are useful, but there's also what's called the NOMAD measure, which is about normalization of complex interventions into practice. And you can use that theory to help shape exploration of how well a complex intervention is being actually adopted as planned. There's other theories like the theory of acceptability. There are many out there, and the complex intervention literature is quite meaty and informative. So I think it's a good idea to look at some of the, if you read the complex intervention framework paper, that's a really good pointer to other things. That for me would always be my starting point about where you find more information. And the last one was, as I say, published just a couple of years ago. So it's got quite a lot of up-to-date information on what's available.
Great, thank you. Just related to frameworks, one thing I saw it on among your last slides, the TIDIA framework. So you see that as mainly as only a framework for reporting, or have you used it in terms of thinking about intervention design and components?
I think it's mainly been, it was mainly generated for reporting. It's as all these guidance or reporting guidance, it's quite helpful to read them to think about what one should be using in one's intervention development. But I see it much more as its rationale is for reporting. But the principles apply. The principle is about transparency over what the components are, what the inverted commas doses, how one might go about measuring fidelity. All of those things will be outlined in the TIDIA statement. So they are very much helpful if you are writing your protocol around what the intervention protocol or intervention manual.
Great, thanks. A reminder, folks, you're welcome to ask questions. I see another question in the chat. I'm just going to read it out. It just came in from Cheryl. Sorry if I missed it during your talk. When you mentioned using both quantitative and qualitative methods to assess the intervention during the trial and guide adaptations, I was curious, how does that process work in practice when it comes to protocol deviations and formal protocol amendments?
Yeah, so I think this is interesting. It's come up in previous discussions about protocols before. And so I think, again, if you're upfront about how you're using your process evaluation, because you're not really adapting you're not changing the intervention. What you're doing is actually sort of making the environment easier for the intervention to be implemented as planned. So, all those things I mentioned about the Roboa intervention, yes, there were changes, about we ensured people were trained, we ensured that they changed where they put it in the emergency room. None of that is affecting the kind of constitution or fidelity of the intervention itself. So it's not a protocol deviation per se, because the intervention is the intervention. What you're doing is looking at ensuring that you are alert to context, and that context wouldn't be attenuating the effect size. So, you are on the alert to say, well, currently the context is not making this intervention freely, and easily available. So, it's important that you feed that back and that changes. So, I mean, from my point of view, it's not a protocol change. You're not affecting the intervention. You are much more looking at these sort of wider elements that are maybe inhibiting you running the trial as planned in your protocol. I mean, obviously, if you have to change things, across the, that may affect the intervention, then it fully goes to protocol change, protocol amendment. But that's not normally the case that we're looking at here.
Great. Thank you. I must say that UK Roboa, I really enjoyed that logo as well, with the device passing through the name with the acronym. That was very well done. I'm not seeing any other questions. So one other question that I had was about those optimization phase trials.
Yeah.
The one where you had the yes, no's, and that
Yeah.
So do those account for interactions, either synergies or antagonisms among the various components? How is that looked at?
So factorial trials in general. So if you get to, it's very simple with two, which is always easier. So if you've got two interventions, one on, one off, both on, you can absolutely measure interactions there. And that's what a factorial trial is almost set up to do. So you can actually get a vague handle on what the interaction, or if there's the possibility for interactions, though that's another really great thing about them. So you can begin to see if the effect of one adds additively or if they are totally independent, and it's helpful to know that in advance. I mean, I have to admit, I have not used the most strategy myself, but there are some really nice papers out there that describe how it's been useful in practice.
Great, thank you. We have maybe time for one more question if someone wants to raise a hand. Okay, I'm not seeing any, so maybe let's wrap up there. I want to be respectful of your time, Professor Campbell. Thank you for an excellent talk. I see your comment in the chat, and I agree, for giving us a wonderful start to our seminar series this year. We appreciate it, and have a good afternoon to you, and have a good rest of the day to everybody here. Take care.